to mitigate and manage those issues that may arise. I'd just like to say I come from the city of Hobart in southern Tasmania, and these are some of the pictures that we've collected over the time of the city of Hobart. It's been a very lovely place to live and work. So maxillofacial surgery, there are a number of indications, and I'm certain that there are other people who are speaking who are far more appropriate at outlining those indications. But my plan is to discuss briefly what the anaesthetic implications are for those risks. So, starting with orthognathic surgery. Yes, you can hear me now. Let's go directly into it. Is that better? Okay. All right. Try not to move around. Orthognathic surgery. There are a number of indications for the surgery. As I mentioned, other people will be more than appropriate at giving descriptions of those. I wanted specifically to mention the obstructive sleep apnea, which is often called because there are significant anaesthetic complications that arise from obstructive sleep apnea both during and following the surgery. However, throughout all of this these surgical techniques, there are issues with shared airways, there are issues with blood loss, there are significant issues with postoperative nausea and vomiting, and there are issues with risk of airway obstruction, including intramaxillary fixation. Is that fair? I wanted to talk specifically, as I mentioned, about obstructive sleep apnea. Now, I understand that there is actually a significant incidence of obstructive sleep apnea here in Vietnam. There's apparently 4 million people that suffer to one degree or another from obstructive sleep apnea. There are a number of screening tools that are used to isolate patients. From an anaesthetic point of view, once it's been determined that a patient has the condition, especially if they're having surgery for maxillofacial surgery to correct the issues of obstructive sleep apnea, there are risks associated with airway obstruction under anaesthesia, and there are risks associated with post-operative complications such as respiratory depression and hypoxia or low oxygenation post-procedure. Patients who have had obstructive sleep apnea have an odds ratio of 2 to 1, or therefore they are twice as likely to suffer from cardiac events following surgery. These include post-operative cardiac arrhythmias, myocardial ischemia, and cardiac arrests. So these patients are not to be treated lightly. The condition that perhaps anaesthetists are most worried about is opiate-induced ventilatory depression. Basically, these patients won't ventilate as effectively, have periods of apnea that normal patients won't have. And this is more common in patients that are, as the age of the patient increases, females, and patients with comorbidities. So the suggestion would be that if you're treating a patient that's had has obstructive sleep apnea, that these patients remain for the recovery period and on the ward, they remain in line of sight of the nursing station. In our hospital, we maintain continuous pulse oximetry for these patients, and we are very careful about the degree of pain relief we provide for these patients post-procedure. So the second indication for maxillofacial surgery is infection. And from an anaesthetic point of view, we are quite concerned about the risk of trismus, or the inability of patients to open their mouths. In my practice, my anaesthetic practice, I'm involved with a surgeon that undertakes quite a lot of temporomandibular joint arthroplasties. And these patients, in general, have a higher incidence of difficulty managing their airways. Difficult intubations, certainly studies in children, show that these patients have 13% of these patients will have difficulties in placing endothelial tubes. They will have up to 1/5 of these patients will have difficulties in mask ventilation, due to the fact that their jaws can be quite rigid and lack mobility. Head and neck tumours are also a significant concern for anaesthetists as well as our surgical colleagues. Head and neck, this is a patient that I gave an anaesthetic to 3 weeks ago. It was a 10-year-old child, and while there were no particular problems, there are risks with upper airway tumours of inspiratory obstruction. There are risks if the tumour is lower down of airway obstruction that cannot be corrected by simple tracheal intubation. And then I've had another case within the last few weeks of a patient post-radiotherapy who has been very difficult a very difficult airway to manage due to fibrosis. So, as I mentioned, head and neck tumours have a very high risk of difficult intubation. There's also risks of venous air embolism and potential risks of airway obstruction as well. So clearly from an anaesthetic point of view, we need to liaise closely with our surgical colleagues about preoperative management and planning ahead. We would often undertake nasendoscopy to determine the degree of airway obstruction, and we would discuss the rescue techniques with our surgical colleagues if we were particularly concerned. In the past, we would often have undertaken a gas induction, which is perhaps something that we tend to do less commonly now for these patients after some important studies about a decade or so ago. Trauma itself, there are risks with laryngeal fractures, which can make intubation challenging. There are risks with the cervical spine being damaged, which can also mean neck manipulation is very difficult. And mandibular or maxillary injury can also cause challenges with airway obstruction and difficult bag mask ventilation. also renowned for its flowers and its gardens, and these are some of the pictures from the gardens around Hobart. There are often a number of comorbidities that occur in maxillofacial patients that anaesthetists need to be very aware of. There are a number of congenital syndromes that are more frequent in maxillofacial surgery, such as Downs, Golden Heart, Guerre-Robin, Treacher Collins, and Turner's. And all of these conditions are very pose problems for the anaesthetist and certainly for the surgeon as well. Along with that, inflammatory conditions such as rheumatoid arthritis, which is obviously a systemic disease rather than simply a joint condition, poses problems from an anaesthetic point of view. Ankylosing spondylitis, these patients may actually be almost impossible to manage in airway. And endocrine or metabolic atrophy with the large tongue can be very difficult. So, and the ways that we can manage initial management in maxillofacial trauma, and these are some pictures of the surroundings of Hobart. Obviously, and I'm well aware that this the ATLS protocol is used here as well. So the airway, breathing, circulation, disability, and exposure. That clearly needs to be followed. But with maxillofacial trauma, there's often the added complications of loose teeth, bleeding, foreign bodies, and collapsed bones in the anterior neck, and the cervical spine that I mentioned before. I might leave that for a moment. What I would like to discuss, or just briefly mention, I won't have enough time to cover it in some detail, but I would encourage everyone to investigate the vortex approach to airway management. And I mentioned that as an anaesthetist, but I also mentioned that to my surgical colleagues, that the vortex approach is an approach that has been developed in the Australian setting, but is appropriate throughout the rest of the world. There's no issues there. And it gives a method that everyone in the room, if there's a difficult airway, everyone in the room can all work together. And everyone will know where they stand and what their role is in the case of a difficult airway. So after a number of mortality events related to anaesthesia in difficult airways, this is an approach that's been developed. And as I said, I would strongly recommend everyone to investigate further. The systematic approach to airway management is the traditional approach, where we look at recognising airway obstruction, we clear the patient's airway, we reposition the patient to get the best possible view, we utilise airway adjuvants to allow us to both provide oxygen through ventilation to the patient, as well as intubate the patient. And if all these fail, or we have planned ahead and decided that they are inappropriate, then a cricothyrotomy or tracheostomy may be considered more appropriate. And this is still valid, this approach is certainly still valid, but should now really, certainly from the Australian perspective, should be the vortex system should be added to this. And just very briefly, the vortex system provides us with 3 attempts at each of these airway management devices. And the key thing is it's only 3 attempts to stop us from spending too much time in the difficult area and getting transfixed on situations where we need to find a frontal axis. Intrathecal intubation, obviously, and there are different types, and I probably won't go into the specifics of the intrathecal intubation. And then, obviously, in extremis, as I was saying, needle or scalpel, crocodile, tracheostomy, and retrograde intubation. The final section of the talk is considering planned anaesthetic management for the maxillofacial patient, maxillofacial surgery. Firstly, it's important to reassess and build confidence with the patient. I think that's paramount to providing a good outcome. Obviously, we need to provide venous access, monitoring. In our setting, we need to warm fluids. I'm not sure that's so important here in Vietnam, but it is important to maintain a warm patient. Ensuring available blood products, eye protection, urinary catheterisation, and nasogastric tube insertion. Well, urinary catheterisation if the case is more than 4 hours, and nasogastric tube insertion. There's a number of ways of providing general anaesthesia, including we often don't use pre-medications except in perhaps in children. It's commonly used. And we would use propofol more frequently than ketamine, but ketamine is still a well tried and tested technique, and certainly used here as well in the discussion of anaesthetic colleagues here. There's just a few specific differences with maxillofacial surgery, longer circuits, different types of intrathecal tubes compared to general surgery. I was just going to mention briefly methods of limiting blood loss that we use. Firstly, it's ideal to have a patient in good health. So ideally a hematocrit of 34% and a hemoglobin of 11. Treating iron deficiency before surgery. It needs to be done a number of weeks at least before surgery. We would usually use intravenous iron, but certainly oral iron if we have enough time. Obviously during the surgery, careful estimates of blood loss. And I'll just mention this. Each degree of Celsius core temperature will increase blood loss by approximately 20%. So in our setting, it's very important to decrease, to maintain patient temperature. We also use, and I've seen this used here as well, tranexamic acid. So I won't go into that in great deal of detail. The other method that we often employ to try and decrease bleeding is hypotension, relative hypotension. As I'm sure most people here would be aware, many of the organs in the body will also regulate their blood pressure. So if the blood pressure falls, the organs will, the vasculature to the organs will alter so that those organs will get sufficient blood to continue to work. That seems to be occur later, is less robust, and the response is slow in scalp and facial problems. So therefore, there is certainly significant evidence to suggest that controlled hypotension, pressures of 68 to 70, will to 70 milliliters of mercury MAC will reduce blood loss by 40 to 50%. So it's important not to take it too low, but lower blood pressures are certainly very effective at decreasing blood loss. And every anaesthetist has their own way of trying to decrease blood pressures. I tend to use remifentanil infusions and sevoflurane. However, I've talked to anaesthetists here that will use calcium channel blockers as their preferred technique. So there's a number of ways to try and decrease blood pressure. It's also possible to consider some reverse Trendelenburg. In the post-operative setting, in our environment, it is important to continue to keep the patient warm. It may be necessary in many of these cases to plan for an intensive care or high dependency bed. And I mentioned the use of transnasal high flow rapid oxygen. We use that where it's appropriate. We use that to maintain oxygenation, and it's very effective. And obviously we need to provide analgesia for these patients. And we will use the World Health Organization analgesic lab, which I'm sure most of you will also be aware of. Right. I just will mention this individual up here is Dr. Ankit Garg, and he asked specifically to be mentioned in my talk. So now I can comfortably say that I have done just that. He is another maxillofacial surgeon that has visited here previously and has indicated he'd like to come back again in the future. So now